You might want to have a glass of water nearby as well. So we'll be here for about 90 minutes.
Okay, you're live.
Hi there. Good evening to everyone here in Parkdale, High Park, and beyond. It's a pleasure to have you joining us this evening. I'm very pleased to be with you tonight. My name is Arif Varani. I'm the Member of Parliament for Parkdale, High Park, and Parliamentary Secretary to the Minister of Justice. And I am pleased to be joined this evening by two very distinguished members of our community who serve our community. And they are two physicians, Dr. Mark Downing and Dr. Fabio Varlese. I'm going to give them sort of a more comprehensive introduction as we move along. I just wanted to do, as I normally do at the outset of one of our events, just do some housekeeping and just let you know how it's going to roll out. So in terms of sort of this evening, obviously Happy New Year. This is the first Facebook Live town hall that I'm hosting in 2021. I want to acknowledge that here in Toronto, we are on traditional Indigenous territory, the territory of the Haudenosaunee, Huron-Wendat, Anishinaabe, most recently the Mississaugas of the Credit, and Toronto is obviously home to many First Nations, Inuit, and Métis people. I think this is going to be a terrific discussion with our guests, and before we get started, I just want to give you some of that outline. So I'm going to provide some brief opening remarks. I will introduce our guests and ask them to give some opening remarks, and that'll take us to about 20 minutes. Then I will moderate a bit of a discussion between the three of us, where I'm going to put to our two guest panelists some of the issues and concerns that have been raised with me about COVID and particularly about vaccinations and vaccines. And then I will turn it over, as we usually do, to all of you, and you can supply in your questions via Facebook and just write them in, and we will put them to our guest panelists and in a manner that allows us to address as many of your concerns as possible. I like to put out some of the thank yous at the outset because I often forget to do it after the fact. So what I'm going to say is, in terms of thank yous, I want to thank my staff who are very instrumental in putting these things together. So that's Amelie, Dawn, Candice, and Hamid in particular, and also thank our two distinguished panelists who I will get to momentarily. So in terms of sort of where we are, I mean, it's been quite a long journey, and I'm sure there's a lot of fatigue setting in, and you're not alone in sort of feeling that fatigue. We know the first COVID-19 case in Canada was reported by Health Canada on January 25th. So almost, a year ago to the day, minus 4 days. Between March 12th and March 22nd, every Canadian province and territory declared a state of emergency about COVID. The last Facebook town hall that I had in 2020 was with respect to the fact that vaccines had now just been approved, and Pfizer-BioNTech had just been approved on the 9th. Since then, a lot has happened. We've had more than one approval of Pfizer and Moderna. We've had a vaccine rollout, vaccines arriving in Canada. We've also had a vaccination campaign starting here in Ontario and right around the country. So in Ontario, the first person to be vaccinated was Anita Kudangan, a personal support worker who received her shot at the Missioner Institute. We had obviously a very different holiday season in December in terms of Hanukkah and Christmas, and it was difficult. It was difficult for, I'm sure, everyone who's participating tonight because we weren't able to be as closely connected to our loved ones and our family as we might normally have been. Numbers are now on the rise yet again. We've got full lockdown here in Toronto. We've got things going on right around the province and literally right around the country. It's tiring. I get it. It's fatiguing. I am also a dad of two young boys, and I know what it's like to sort of be dealing with the online schooling situation. Same time, you're trying to juggle work and other commitments that you have. And it's not particularly fun for any of us. Obviously, I think I see vaccines as a light at the end of the tunnel, and I know I'm not alone in that regard. But I'll also say to you that I wanted to host this town hall about vaccines and on vaccine hesitancy because I was a little bit surprised, to be candid, in terms of how much questions, concerns, skepticism, and cynicism that I was hearing from Canadians, from my constituents, and from people right around the country online about vaccines. And there have been a lot of concerns, obviously. First of all, it was, can we get the vaccines approved? Secondly, it was, can we get them here? Then once they were here, we started to hear from people about, well, I'm not sure if I want to take them. And my job and the job of our government is obviously not, it's not about forcing people to get vaccinated. My job is to make sure that people are armed with the best information to make sure that they can make an informed decision about whether to be vaccinated. And what I want to do as your representative and your member of parliament is ensure that you have access to the best information. and the most up-to-date information, the most accurate information, including from scientific and medical authorities. Thus, I thought about hosting this town hall and about having some significant authorities with me to field your questions, people that work in the field, but also work right here in our community. And what I also want to express to you is that it's about hearing from you. It's not about judging people. This is not meant to be some sort of exercise where people are pointing fingers at one another. This is meant to be an exercise that's an open exchange of dialogue and hearing people out. This is not about passing judgment on individuals. There's literally no question that's inappropriate, except maybe if you're asking me about Austin Matthews' wrist shot and the Maple Leafs, the state of the Leafs, things like that, maybe veer a bit off target. So we'll try and stay focused on what we're addressing. And I wanted to say, just before turning it over to our two doctors, one thing at the outset, because I know this must be on a lot of people's minds, is that in terms of the supply of vaccines, yes, we are having a temporary curve in the road with Pfizer and with their plant in Belgium. That's painfully obvious to everyone who's following the news. What is happening right now is that we are not going to receive Pfizer vaccines in the week of January 25th. But the most up-to-date information I've received from my colleagues in the cabinet is that we will have 79,000 Pfizer vaccines coming in the week of February 1st. The delivery of the Moderna vaccines continues as normal. But I think the most important message I can convey to you is that this does not deviate us from the broader course. And this is not a sprint, this is a marathon, as we've known and have known now for 12 months. And in terms of the milestones we have set, we are still on track to meet those milestones. And Pfizer has assured Minister Anand that we will indeed meet those milestones. And what are those? I'll just remind you. What we've said is that we will vaccinate 3 million Canadians by the end of March, and we will vaccinate every Canadian that wants to be vaccinated by the end of September. So that has not deviated, that has not changed. That trajectory and that timetable remains intact. And one of the reasons why we can be assured of that is because we've gone to great lengths to procure far more vaccines than we would require to vaccinate everyone in this country. So upwards of 400 million doses from 7 different companies, because we anticipated hiccups and roadblocks in the supply chain, and this enables us to be nimble and dynamic in our response. So I just wanted to put that out there. We're going to cover a large number of topics tonight, and I encourage you to visit canada.ca/vaccines for accurate and up-to-date information on COVID-19 and vaccinations. And I'll ask Hamid to actually put that link up in the up on Facebook, so you've got it and you can note it down. Canada.ca/vaccines. So let's get to the people that we're about to hear from tonight. So these two gentlemen who are joining me tonight have very long bios, and I asked them to shorten them, and I've edited them even further. But the first person I want to introduce is Dr. Mark Downing. So Dr. Downing is the Associate Medical Director of Infection Prevention and Control and the Medical Director of Antimicrobial Stewardship at Unity Health Toronto. Despite these long-winded titles, he's assured me he's going to simplify a lot of what he says this evening. He's based out of St. Joe's, so right at the foot of Roncesvalles, where he previously served as the division head for infectious diseases. And one of his primary areas of focus in 2020 has been the support of long-term care through the COVID-19 pandemic. He's the medical lead for Unity Health on that front. He represents stakeholders at the regional level and participating in on-site reviews, weekly community practice meetings, and outbreak management. He also happens to live in High Park, so he's also a constituent and a member of the community. So Dr. Downing, thank you. Thank you for everything that you're doing in terms of your personal sacrifices, your family sacrifices, your professional sacrifices to keep all of us safe and healthy right now. I imagine if it's been a tough year for folks that are watching, right now it's been an even tougher year for people like you on the front lines of the healthcare system. And thank you for everything that you're doing. And over to you for about 4 to 5 minutes, and I will try and play bad cop and keep us on time. Thank you, Dr. Downing. Over to you.
Great, thanks, Sarif, and it's a pleasure to be here. I know you've been a good supporter of St. Joe's, and I've seen you speak a couple of times at our events, so I'm happy to return the favor here. And as you said, I'm a member of the community here, and so partly I'm interested in what others have to say, but also as Arif has mentioned, my primary interest is in hospital care and long-term care, and in particular with the pandemic. And Arif, I'm happy to just keep rambling, so please cut me off whenever I've said too much. And I'm sure we'll get to some of the topics, particularly around the vaccine. But just to give you some background, before 2020, I worked exclusively in the hospital. I managed outbreaks there. And I would treat things like HIV and tuberculosis and some other infectious diseases that we more commonly see in Toronto. But then everything changed last year, and more I focused on long-term care because that's where the pandemic has hit the hardest. And I think many of you know that about 80% of our deaths in Canada are in long-term care related to COVID. And so that really is where the need has been. And so that's where we've gone. And so I've been out to a number of facilities on multiple times, and we have a network set up now where we support each other. And I think that really is the most meaningful work I've done over the past year, is being on the front lines in long-term care, which really do seem like the true front line for the pandemic. So I'm happy to talk lots about the vaccine, sort of I was thinking more of like the who, what, when, where, like what is it, who's getting it, where can you get it, those sorts of questions. But maybe I'll just end there for now, and we can circle back to all the other stuff.
Thank you so much, Dr. Downing. And I'm a bit shocked as a litigator who's used to strict time limits imposed by a judge. You've come in under time as a physician, but thank you very much for that. I do appreciate it. I want to turn now to Dr. Varlese, and I'll say the same thing to you, sir, in terms of sort of what you're doing at Runnymede and as a physician. And I know you've been contributing to this effort, not just domestically, but globally. So I do appreciate that in terms of your commitment as a person on the front lines doing this work. I know it's the work you were called to do as a physician by profession, but obviously this has been a year really like no other. In terms of Dr. Varlese's biography, it is equally substantive, so I'm going to come back over to it here. Dr. Varlese is a prominent specialist in internal medicine and geriatric medicine, graduated summa cum laude at the University of Rome, so benvenuti, signore. He specialized in internal medicine at the Cleveland Clinic Health System. He since then has also specialized in geriatric medicine at U of T and is licensed to practice medicine in Canada, in the United States, and in Italy. In addition to his current responsibilities, and the reference I was making there to Italy is that I understand Dr. Varlese actually returned to Italy when things were very difficult there in the spring of 2020 to assist in the COVID efforts there. In addition to his current responsibilities as the Chief of Staff at Runnymede Healthcare Center, so that's right in the junction here in the riding, is also the staff specialist at Baycrest Health Sciences and Mount Sinai Hospital, and he holds the current rank of assistant professor at U of T. So obviously no shortage of expertise here in terms of our panelists. And Dr. Varlese, thank you for your contributions in the fight against COVID-19, and thank you for joining us. So over to you for about 4 or 5 minutes.
Arif, it's an absolute pleasure, and I really, truly thank you for this opportunity. I could say that I'm not a resident in the community, but I've been spending a lot of hours since I've taken on the position as Chief of Staff and Vice President of Medical Affairs at Runnymede, and it's been an absolute pleasure to get to know your community. It truly is a wonderful place, and it's becoming so familiar to me and sort of like home in a way. As you mentioned in my background, I've one of the biggest focuses has been for at least 12 years to lead and manage an acute care geriatric unit of 27 beds, and I was caught right in the middle of SARS, going back in, was it 2000, I believe, in 2, and had 2 negative pressure rooms, and it was tough then, but I don't think that we were thinking that this a second wave like this would be this significant. I think that we should always think that and be ready for the worst. But I think that SARS at the time was more, something sort of confined in the hospitals. But when there's the community spread that we've been seeing with COVID-19, clearly there's a huge impact at all levels, and I'm honored to be part of your community now and part of the management of this wonderful hospital. led by a visionary CEO, Connie Jack. And I know you, Arif, have been an incredible supporter of our hospital and the community. So, I'm just here hoping to be able to answer what it is I can. And clearly, with my background in geriatric medicine, as Dr. Downing pointed out, this is a very, sort of important sort of group in our community that we really need to pay a lot of attention to these days. And we're learning so much, but it's never enough. So I'm happy to answer any questions.
Thank you so much, Dr. Varlese, and thank you, Dr. Downing. So why don't we get right into it? And as I mentioned at the outset, I'm going to sort of steer the conversation a little bit before we turn it over to the questions that are coming in on Facebook, and they're already starting to come in. But let's just start with some of the basics. I understand from having chatted with both of you that both of you have been vaccinated. So Dr. Downing, why don't I just turn to you first, but just, can you just tell me and explain to the audience what is a vaccine and just how do they operate, just in the normal course? Dr. Downing.
Yeah, so I think most people know vaccines were like a true revolution for humanity in general in terms of preventing disease and mortality. And how they work is by giving your immune system something that looks like the virus so that your immune system can recognize that virus when it sees it and contain it before it causes an infection. And so when we talk about the two Health Canada approved vaccines, Pfizer and Moderna, these are vaccines that use something called mRNA, and I think this is new to a lot of people, but not necessarily to the scientific community. And this is technology that's been used for many years for things like cancer treatment. And so what this mRNA does, and our own bodies have used mRNA to, it's a way of communicating to the cells to make proteins. So instead of giving your bodies the proteins themselves from the virus, we're giving them the mRNA to tell the body how to make the proteins so that it can trigger an immune response so that if you ever see COVID down the road, your immune system will recognize it and contain it. I think it's very important to know this isn't giving someone COVID. This isn't a live vaccine. It seems very safe based on the large studies that we have so far. There aren't significant side effects that have been identified outside of the rare allergic reaction, which is common with most vaccines.
Okay, and I want to explore some of that in terms of the side effects, because in my research, and you try and become a little subject matter expert, I felt like, when I was a lawyer, I'd become a subject matter expert depending on the case I was arguing. Here, I understand that Health Canada is actually tracking the side effects, and they've found only 5 instances up to the data that was analyzed in the first sort of tranche out of well over 100,000 sort of examples of delivery of the vaccine where people had significant side effects. So is that, from your perspective, so Dr. Varlese, from your perspective, is that sort of a good statistic? It seems fairly good from my perspective, but in terms of going towards that safety sort of component and that tracking that people are doing. So Dr. Varlese, could you weigh in on that piece?
Sure. I mean, this is pretty much expected, the numbers that you're talking about. No, we should distinguish that, once again, that these vaccines don't cause the disease. If side effects do happen, if they're mild, it's just your immune system trying to react to the particle in the vaccine. So it's not a sign of you developing the infection. We hear it every year with the flu vaccine that, oh, I ended up basically getting the flu, but really what they got were sort of like those symptoms that are caused by an immune system that is trying to react to this foreign body and therefore develop the immunity that Dr. Downing has pointed out that you need. You will not get sick from the infection. And then there's the... Yes, go ahead.
Sorry. Well, I understand both of you have also already been vaccinated, and I say this somewhat facetiously, but I'm an elected representative, and I feel any elected representative reflects on me in some respects. And I know there's been leaders around the planet who have sort of peddled ideas about, you're going to grow a beard. I note that both of you already have beards, but you're going to turn into a crocodile, etc. So can you just explain? I mean, I'm not in that tranche, right? You guys are in that first tranche because you're providing services. There are people who have been targeted for sort of as the first subset or first group for vaccinations, and rightfully so. So what was it like? Was it painful? Did you personally experience side effects? So if both of you could take a stab at answering that, I think that would be helpful for the audience.
Go ahead, Mark.
Yeah, and first of all, I had the beard before the vaccine, so I'll put that out there.
Okay,
I'm not
thank
sure
you.
about you, Fabio, but
Same.
what I would say, so yeah, and first to be clear, I wasn't in the first tranche of individuals that were vaccinated, and I think as healthcare workers we are a bit conflicted about where we are in the line, and so my messaging to everyone is you should be at the first of the line signing up for it when it's your turn. And I think it's important to acknowledge that there are certain groups that are at very high risk, and in Ontario it was long-term care. And so before I had an opportunity to get the vaccine, we really focused on getting staff and residents and essential care partners in long-term care vaccinated. So after that was our turn, and I certainly signed up as soon as I could. We initially had our clinic at St. Michael's Hospital, which if any of you have gone down there, it really does look like a world-class vaccine clinic. It's really quite amazing. It's a brand new building. It really is a rather straightforward process. So I went, you have to consent, obviously. So you consent both to releasing some information to the government so that they can track you and your symptoms, which is fairly normal. And I think good to monitor for any side effects from the vaccine. And then also consenting to the vaccine itself. And then they screen you for any reasons why you shouldn't have the vaccine, which at this point are very minimal. And it's really, do you have an allergy to something called polyethylene glycol, which is a component of the vaccine? Or if you're under the age of 18, because it hasn't been studied in that population. But otherwise, it's relatively, it's encouraged for anyone within those priority groups at this moment, including pregnant, breastfeeding individuals, people with autoimmune conditions, if they've had a conversation with their healthcare provider about the pros and cons, understanding that we don't have as much data in those groups. And so after that process, you get your shot. It's just like having the flu shot. I barely felt it. I actually felt quite exhilarated, and I don't know about you, Fabio, but it's a real release after this whole year to finally like have something very physical to say, yes, I think this is real, and I can kind of see the light at the end of the tunnel now. So it's actually pretty emotional, I think, for a lot of people, including myself. And then you have to sit and wait to make sure you don't have an allergy afterwards for 15 minutes. And so you're sitting around with your colleagues looking at them, everyone's kind of grinning, giddy like yourself, and then you're done. And that's really the process. I've heard of very few people having serious side effects. I had a sore arm, which I was kind of pumped about because that meant the vaccine was working. And that was better within a day or two, and then I felt fine. And I'm due to get my second dose next week, hopefully, depending on what the supply is like, and I'm looking forward to that too.
Excellent. And Fabio, did you want, Dr. Varlese, did you want to add to that? Your
So
experience?
I totally agree with everything that was said. I could also say with some level of pride that at Runnymede, our own staff is being vaccinated on location. And so we initiated by visiting Humber, but days later, we were able to become independent in delivering the vaccination to our own staff. We've created all sorts of safety guards, and we have a beautiful system going on, much of what you heard from Dr. Downing in terms of the sequence of things and the structure of the clinic itself. I received, again, also my first vaccination. I was the first one to receive it at Runnymede. And again, a bit of soreness to the deltoid muscle. absolutely no symptoms. And yes, I felt exhilarated because perhaps there's a psychological component to that because, you know, we've gone through an incredible year. And so I totally agree with Mark on that.
And is the soreness, you said, Dr. Downing, you said the soreness indicated to you that it's doing the work it should. So, because that soreness, like when I get a flu shot, I'm kind of usually bummed out about a bit of soreness in my arm, but that's actually something to be welcomed. Is that the sort of the messaging I'm to take away from that?
Yeah, I mean, the vaccine is trying to activate the immune system. So a lot of these side effects are the immune system getting a little too excited. I think a sore arm is kind of the sweet spot where, you know, it's working, but you know, you're not getting into some of the more rare side effects like a fever or something like that. That's not to say if you don't have any symptoms at all, it's not working, and that's great if you do. But I think at least like 3/4 of individuals will get a sore arm. That's kind of the main side effect.
And tell me, because I'm sure this is going to come up, but I'm going to take the moderator's liberty to ask this question. But now you've got the one dose. You're supposed to get a second dose, but what impact does it have now in between doses and even after the second dose in terms of what you're supposed to be doing? Do you stop washing your hands? Do you stop wearing a mask? Do you start sort of nuzzling up to people on the bus? You know, because people are generally concerned about this kind of stuff. Like, does it give you this this ability to be completely safeguarded no matter what, and you can throw caution to the wind, or do you still need to be observant of public health guidelines? So Dr. Varlese, why don't you take this side?
Sure. So first of all, immunity starts building from the injection over time. So it's not like, oh, I received my injection, I am immune, number one. So it's a gradual process up until the second sort of shot that you receive. You may be immune 50%, and then you kind of receive the second one, and it takes a while again before you really develop it up to 94%. There, at no time do you change your habits, because you can still transmit COVID-19. You could be an asymptomatic carrier still. You could be, you could be somebody carrying it. And the whole point of the vaccine is to have a direct impact on the severity of the disease, certainly having an impact on mortality, preventing death, but more importantly, also on the severity of the disease. And with this amazing accomplishment that we've been able to achieve in such a short period of time, it doesn't change our behaviors. We need to continue to wash our hands, wear the mask, take a walk, and interact at a safe distance. Nothing changes, but and Mark, I don't know if you want to add to that, but I think that there is this false thinking process of thinking that the vaccine equals I could totally break down and go back to normal. Not just yet.
Yeah, and there's also this thing called herd immunity, where no matter how good the vaccine is, it's not 100%. And if there's a large enough continuous exposure because others around you aren't immune, you're still at risk. And so I think that's something to keep in mind. That being said, I think at some point there will be policy changes based on who's vaccinated, and we're definitely not anywhere near there yet. But I can see a future where we do start to relax these things, in particular if you've been vaccinated or if you've recovered from COVID.
Thank you. And let me explore what you referenced just before you pass the baton to Dr. Downing, Dr. Varlese, because you mentioned the speed of the approval. And some people, there seems to be a huge sort of like spectrum of opinion on this. Some people see this as a monumental feat of human achievement and scientific achievement. And I, as a government representative, think about it critically and sort of say, well, why did this happen in this context? And I've got things that I can impart to people that, often nation states and companies compete. Here, everyone is driving towards the same goal, not in a competitive way, but in a collective objective manner. Tons of resources were dedicated in a way that the world has never seen. We had the ability to build on some of the old information from other illnesses. You mentioned SARS yourself, Dr. Varlese. And there was a lot of contemporaneous sort of things that were going on. So testing and approvals were being done in a rapid fire manner. And I literally know from Patty Heidi, the Minister of Health, that there are people working literally 24 hours a day on getting these approvals through. So I can sort of explain those points to people, but I think people are generally saying that, you know, when I take that flu shot, I know that that's been studied and it took 10 years to approve that one particular strain of a flu vaccination. Why should I trust something that took 10 months instead of 10 years? So how did the two of you respond to that concern? Because I hear it all the time. So why don't we start with Dr. Downing?
Yeah, so there's besides what you pointed out, which is everyone was working together towards a common goal. I think the stakes were high, and that did motivate a number of things too. So there was a huge investment put into this without any certainty that it was going to pay off with some of these vaccines. So to some extent, that gambling did pay off with some of these initial vaccines because they have shown to work. But they built huge facilities, not knowing if the vaccine would ever make it to the point where they would be able to produce it. They also had people working around the clock on research. And so normal research is like a 9-to-5 sort of job, or longer depending on what the deadlines are. But in this case, they literally were just doing shift work trying to get the vaccine out. So I think that helped to speed things along. And then I think, as you said, the most important thing is the government and the private industries working together to reduce that red tape, because sometimes with approval processes, they just take a long time because there's no urgency to getting some of these drugs out. Whereas here, you can speed up that process without compromising it. And that was kind of the main thing to getting this forward. So I think it is truly amazing and remarkable, and really what's going to change the pandemic, the speed at which the vaccine was produced.
Dr. Varlese, thank you.
Yeah, well said, Mark, and no doubt. I mean, I think it was up to 200 companies that applied for grants and with their own respective governments, and what a huge effort. I also read on the Pfizer group that already sometime in January of last year was really following very closely what was happening in the East. And they deployed like close to 500 scientists. So you imagine the amount of brain power that is being put into something like this, because they could kind of predict how this could get out of hand already early then. And and certainly cutting the red tape is a big one. The bureaucratic hurdles into just going from one step to another, one phase to the next, those were cut. That didn't affect, I feel, the quality what has been produced. And don't underestimate, like, I mean, we talk about September when everybody should be vaccinated, but there's other companies like AstraZeneca coming with a more traditional type of vaccine, a modified adenovirus, something that we're way more familiar with. They're around the corner. I hear they'll be approved by the end of this month. There's Johnson & Johnson, that is some different type of vaccine, a double-stranded DNA type of vaccine, which also is not far away. So think of it, massive effort, a lot of people coming to the table with their own evidence, going through the process of approvals from FDA's and Health Canada's, and then who knows, maybe the success of many other companies will even shorten further our ability to vaccinate everybody, so that the opportunity to return to some level of normality is possible. So yeah, so it's very exciting, to say the least.
And thank you both of you for the input, and I'll definitely elaborate on that in terms of there's 7 different potential candidates. 2 have been approved, but AstraZeneca and the Janssen one, the Johnson & Johnson one, are the next in line. And I believe it's the Johnson & Johnson one that is a single dose, which has its own appeal for other reasons. Let me put to you another question, because this has come up. Other people have said, well, okay, so maybe it's out there, and maybe I accept all of those rationales that were just given, but I still don't want to be the guinea pig. I don't want to be the trial, the test. notwithstanding there are tests that have been done and that's met with approval in various countries. I don't want to be first in line. I'm happy to go in April, but I don't want to go in January. And then, people that are reading the news are noting that there's even some people in your field of work, gentlemen, that don't want to be first in line. So we've heard some nurses don't want to be first in line. So maybe could you unpack that a little bit in terms of the I don't want to be a guinea pig phenomenon, and how does one who's a layperson, not medically trained, interpret somebody who's got more medical training still showing some resistance? Because that, I'm sure, would give people pause. So maybe Dr. Varlese, do you want to try that first?
Sure. So I mean, I think that as physicians, obviously, we look at what we're dealing with here. And yes, it is true that mRNA vaccines are relatively new, even though the technology, as Dr. Downey pointed out, has existed already years ago, in particular for the field of cancer care and treatment. But we're dealing with, some genetic material right now as we speak. We have bacteria, we have viruses, we have fungi all over us. They're part of us. There's nothing, crazy about that. In fact, most of these, bacteria and fungi are there for a reason. Our immune system is used to their presence. mRNA is genetic material that we encounter on a regular basis. When we look at it, I guess we're looking at this genetic material. We're looking at the vehicle that is transporting this. We're looking at all of the elements in this vaccine that seem to be totally innocuous. Listen, I mean, to us, if I'm trying to bring it down now we don't see anything in this vaccine that would be harmful in any way, shape, or form. And let's not forget, we've been vaccinating communities around the world going back to from the literally 30s, really 40s and 50s. But, and we have become a bit complacent about what type of impact vaccination has had over the past decades. And medicine in the 40s and 50s, wasn't what it is today. So I think we know what we're talking about here. Listen, every foreign body, any medication, aspirin. Well, aspirin is over the counter. And yes, I'm sure that Dr. Downey and myself have seen, patients that have had a bleed in the brain from an aspirin, or a bleed in the gastrointestinal system. There's always a risk with anything, the medications that everybody's taking every day. It's a benefit versus risk. We just don't feel that the risk is that high because of what I just explained before and what this is made out of. Dr. Downey.
Thank you. Dr. Downey, yeah.
Yeah, and just to build on that, you wouldn't be guinea pigs at this point. Like, millions of people have been vaccinated, and even at Unity Health Toronto alone, we've vaccinated over 10,000 individuals already, and we haven't experienced a severe adverse event. So I think that's we have the local personal experience now, which we definitely wanted to see, because the studies have been done if you look at the 2 Moderna and Pfizer studies, those were done in over 70,000 people, which is a large number and very reassuring. But it is nice to actually see these individuals yourself and have the vaccine yourself and be doing okay on the other end. So I think certainly there are the rare side effects, which we see with any drug, as Dr. Varlese has mentioned, but these seem very safe. And the other thing is, we know what COVID does to people. And so everything is a weighing a risk and a benefit. And at this point, COVID is so prevalent that if you don't get the vaccine, there is still a very good chance you will get COVID. And we know that even in young, healthy individuals, there may not be a significant risk of dying, but we are seeing a lot of this long haul syndrome that they describe, where you have symptoms for months. And even more so, it's about protecting the more vulnerable people around you. And so even if you're young and healthy and worried about being a guinea pig, I think if you speak to our long-term care residents, they are more than willing to be guinea pigs, even though they're not, because they know what the risk is. And if you look at our numbers across our homes, over 95% of our residents have already been vaccinated. And it's an incredible number, but I think they really understand the risk. And to some extent, this is kind of what we owe them, and that herd immunity is to get vaccinated as well.
So that's a useful segue, because I want to ask you guys two more questions and then turn it over to the audience. So, and it relates to sort of the specific clientele that you guys serve. And I want you to connect the dots for me, because I do experience and know of a lot of sort of sentiment that people are saying that, yes, the deaths are occurring and they are a tragedy. They're an abject tragedy in terms of what's happening, 80% of the deaths being in long-term care homes. But I think what it's done is it's built up a sentiment for people that aren't in that demographic, aren't resident in a long-term care home, to sort of say, even if I contract this, it's likely not going to affect me fatally. So what's the point? Why do I need to take precautions? Why do I need to get vaccinated, et cetera? So can you connect the dots between how, you know, grade 12 students or a 25-year-old or a 35-year-old person, how them not getting vaccinated ends up potentially imperiling the folks at Runnymede or the folks at various long-term care homes that you visit? So why don't we start with Dr. Varlese?
So that's such a great and very important question. So basically, it kind of goes back to the concept of herd immunity. So, you know, you can achieve herd immunity without, you know, vaccination. Nothing that I would advise in this case, to be honest with you. People are going to get the disease, and a lot of people are going to die. That's just not the way to go. But the vaccination program is what gives the immunity to those individuals that are going to be caring for the more frail population in our community, you know, and they're the ones that, if they're carrying it and they're not immune, they have a higher chance in transmitting always. And yes, you know, I said before that you still need to continue to maintain those precautions of social distancing and, you know, using masks and washing hands, etc. Even after immunity and vaccination is achieved up to a certain point. But it's all about herd immunity. It basically, it's when most of a population is immune to an infectious condition, and this prevents communal spread. This is the reason for vaccinating, and that ultimately has an impact on mortality, on the number of deaths, and that's why it's important. When we look at a pandemic like this, it's not about me, it's about our community, not only our friends and loved ones, but the community at large. So that is why it's important.
And Dr. Downing, can I, before you respond on that piece, can I just add another layer to it? Because Dr. Varlese mentioned sort of vaccinations having been around since the 30s and the 40s. My wife works in public health, and she's a dedicated professional like you are, working way too long hours, et cetera. Prior to us settling down here, she had the chance to work in India. We were both in India. She was working on polio. And I raised this because one of the battles there was just overcoming some of the cultural barriers, some of the sensitivities. So I want to ask you about that. I know you work closely with Unity Health, and St. Joe's works closely with Copernicus Lodge, primarily Polish retirement residents at the foot of Roncesvalles that has had an outbreak, a very dangerous outbreak, very, very recently. I'm concerned about that, as I'm sure everyone in our community is, but I also know that sometimes people are resistant based on things that they hear about. Sometimes it's based on media that they're consuming. Sometimes it's based on perceptions from the home country. How do we overcome things like that? Do we need different types of leadership examples? Maybe people are less likely to listen to an elected leader or a doctor, but they might be more likely to listen to a religious leader, for example. That was definitely a tool that was used by my wife and the WHO when they were dealing with polio in northern India. They used religious leaders to earn the trust of individuals. If you could comment on that, because as a tangible point that I just read about, we know that PSWs have been on the front lines of this and have felt neglected in some respects by elected officials. And PSWs are also disproportionately women and people of color. Talk about Filipinos. In my writing, talk about the Tibetan community. How do we overcome some of the barriers that might exist amongst groups like that who are already been, unfortunately, very affected by this virus, and get them to the point of getting on board with vaccinations? So a big question, Dr. Downing, but very curious for your thoughts, and Dr. Varlese, and then we'll go right to the audience. Thank you.
Yeah, thank you, Arif. And I think that that truly is, I think, the main challenge here. And a lot of it is about trust. And you're right that I think only so many individuals are going to trust physicians or politicians. And so it is important that the message is coming from all areas. And I think this is where anyone can be a true leader. And, I think if we have a Globe and Mail video about the first person we vaccinated at St. Mike's, and it was a PSW from Providence, and she told a very powerful story about how she just she felt like initially she was scared. She had heard some things, but she brought some friends with her to gather courage, and she feels kind of invincible now. And so I think it's getting that that feedback from your peers in particular that helps to motivate people, but also patients, family members. Like I think that message needs to be consistent from all groups and religion as well too. And yeah, I think out in it's maybe a bit easier in the hospital setting because I'm right here, I can see my colleagues and talk to them. And so that's why we focus so much on some of these other congregate settings, not just long-term care retirement homes, but shelters and other places that are higher risk, to try to spread the message. And really it's just about listening. And so that's why these town halls are so good, because I really just want to hear from people that are hesitating to understand why. And I think it's for a number of reasons. One in particular is that at one point we thought we had a lot of vaccine. And so I think a lot of people were just willing to wait. And now that we don't have so much at the moment, I think that is spurring a lot of motivation. But also I think there are other reasons, and you can only spend so much time on the science or our personal stories. And I would like to hear those other concerns too, and just see where we can address them. But obviously I can't address them all myself, and that's where other people are important too.
Sure. Okay, so on that note, why don't we turn to some of those audience questions, if that's okay, Dr. Varlese and Dr. Downing?
Yes, absolutely.
Okay, so I'm just going to take them in the order that my assistant Hamid has been sending them to me. And the first one in is Hillary West, and it's sort of rapid fire. There's quite a few of them in here. But she's asking about, for example, have they now determined scientifically that the second shot can be delayed for a certain amount of time and be considered as effective as originally thought? We know that the first set of delays was around, spacing was around 21 days. And I know WHO and NACI has thought about, perhaps relaxing that a little bit. So your thoughts on that? Hillary is also trying to understand the risks given what seems to be an uncertain supply chain. What if Moderna also has delays? So I can try and tackle some of that if you like, but curious for your thoughts, gentlemen. She also asks, are some vaccines considered more or less effective for people over 50 or over 60? So is there any sort of tracking on the timing of it? And then she's asking a bit of a legal accountability question, which I can try and tackle as well. If someone's second shot is not administered according to manufacturer's specifications, and the person gets COVID-19 and seriously ill or worse, who would be ultimately accountable? So if Dr. Varlese, if you want to try and tackle some of those, and I'll try and
well, I could say something about the scheduling. I mean, obviously, Pfizer says, for sure, 3 weeks after your first dose, but in reality, it could go as long as even 12 weeks after. So I want to reassure everybody that that so far the evidence that I've been able to see is telling us that it is not going to be a problem to extend that much after the third week with the Pfizer vaccine. In fact, there is some reporting as far as up to 12 weeks after. So that's an important reassurance. And you've heard that Moderna is usually 4 weeks for the second dose, but it kind of follows the same pattern. Same thing with the upcoming AstraZeneca. It's going to be like a 4 to 12 week. So I think that even in a situation where there's shortage, there's a, we're making sure that those that have received the first dose, in fact, will be receiving the second dose, but we also do have a buffer, and it's okay, and it will not have an impact as long as it's within the parameters that I mentioned. But Mark, do you have anything to add to that?
Yeah, I think certainly this is needing to delay the vaccine is something we weren't necessarily expecting, but we were prepared for. And I think if you look at any guideline produced about vaccine scheduling, there is usually a chapter on what if there is a limited supply, what is the contingency plan? And it usually is spacing out the vaccine. And part of it is that we know that the first dose does provide the bulk of the short-term immunity. And so there has been some good modeling in Ontario to suggest that you really should vaccinate as many people as possible with that first dose to save lives. And we've done that, but with the expectation that we would have that second dose. And unfortunately, there has been a bit of a hiccup, but we have a plan for that too. And if you look at the studies, so the initial Pfizer and the Moderna studies, they did allow patients into those trials that were vaccinated up to 42 days after the first dose. So there is evidence for that. Also, if you look at other multi-dose vaccines, we know the longer that you wait to give the second dose, actually the better the immunity is. So there's no reason to think it's not different with these vaccines. So obviously, I had a colleague who kept saying, "Oh, it stinks. What's going on?" And I think that's kind of an apt description of what it is. It kind of stinks. But at the end of the day, I'm actually quite comfortable if my dose does need to be delayed, like understanding how the vaccine works. I think what we're doing is the correct thing, and that is not holding back doses initially. I think that would have been truly unfortunate if we had just held back doses because we wanted to make sure everyone got their second dose, and they will get their second dose and within a reasonable time frame.
And any response? Thank you, gentlemen. Any response to the question about is there a sweet spot for choosing which vaccine based on your age? Do we have any scientific understanding on that piece? That if you're a certain age, you should try Moderna as opposed to Pfizer, or vice versa?
I think when we talk about the over 50 population, they were included in both studies. The studies also included a broad range of ethnicities. They really did try to reflect the general population, at least in North America. And so I think, obviously there is some selection bias still, but I think in general, we have been able to apply these results more generally. I think when we talk about the elderly and long-term care, that's a population that wasn't necessarily studied in these studies, but we think the safety is okay. It's really just a question of, is the efficacy still there? Because as you get older, and certainly Fabio can talk to this too, is that maybe your immunity isn't quite as good anymore. And so maybe you don't react to the vaccine as well in terms of the efficacy, but in terms of the safety, it should be just as good.
Okay.
Absolutely.
Thank you very much. And in terms of my response to Hillary, is it possible that there could be delays on some of the other vaccines? Yes, of course, anything is possible, but I think the only assurance I can give you is that that's exactly why we procured from 7 different companies, 2 of which have been already approved and 2 of which are literally en route. You heard Dr. Varlese references. The AstraZeneca one and the Janssen approvals are en route, and in some respects could be arrived at in fairly short order. So that gives us at least the additional flexibility to respond in case there are any other hiccups in the supply chain. So let's go to the next question. I've got Diana, and it looks like it might be in 3 parts, but I'm going to try and parse it here a little bit. What are the long-term studies in relation to mRNA technology in humans? Why haven't other medical interventions using this technology come to market in the past over a decade of development? Is it true that mRNA coding, okay, this is really technical, trigger immune reactions and liver damage? and how long does the effectiveness of the vaccine last? And that last piece is probably the simplest one for me to understand, but I had a question that related to that in terms of, is it possible we may see in the evolution of this something similar to what we see with the flu, that you might need a COVID vaccine again next year? There's a new variety of the virus that's out there, and it becomes sort of an annual phenomenon. Did you need me to repeat those first two ones, or did you get the technical verbiage? Okay, so over to you. So why don't we go to Dr. Varlese first about the mRNA questions, and then the longevity of the effectiveness of the vaccine. Thanks, Dr.
So the longevity, I mean, is being predicted for at least a year and a half. But again, we don't know how COVID-19 will behave. Is this going to become seasonal in nature? As you know, you've been hearing a lot about new strains, and let me just say very quickly that there is no evidence so far that the new strains will not be covered by the current vaccines that are being produced. So as much as a new strain sounds like, oh my God, here we are, we have a vaccine for the old strain and now there's a new strain, and what's going on. And I think it's important to clear that very quickly, that it'll be safe and it'll be good enough to cover for the new strains. But yes, the seasonality of this is a big question mark. There is certainly that potential that this can be recurrent on a yearly basis. But one thing is for sure, that here we are. We've done so much in such a short period of time. It may take on the looks of what is similar to the flu, the yearly flu. And if it does, I think that technologically we have advanced so much in not even a year to be able to look at the next year with a bit more confidence. I think that the questions on the mRNA aspects, perhaps I can defer to Mark. Mark, you were about to say something, I think, about them.
Yeah, I think in terms of I don't have the exact numbers, but there have been large studies, sort of pre-clinical trials in healthy volunteers looking at mRNA technology for cancer therapy, but also early studies looking for other vaccine candidates. And the flu vaccine is one where I believe that I can't remember which company of whether it was Moderna or Pfizer was in the process of developing an mRNA vaccine that could target the flu. And so I think the technology is not new. So they have had long-term follow-up with these patients. No signal has been identified. And I think now that we've vaccinated millions of patients, these patients are being followed too. So the patients from the initial studies, there is still plans for onward follow-up up to a year or possibly two, to see if there are any longer term side effects, and they just haven't been seen yet. And so I think that's all very reassuring.
Sorry, I was on mute. That's the quote of the last 12 months. Something that was reassured to us in caucus from the various cabinet ministers is that also that Health Canada approval it's very much an ongoing exercise. It's not as if once the approval is given, the scrutiny just abates. The scrutiny is ongoing and it tracks people, as you had mentioned. So thank you for raising that again, Dr. Downing. So a question here from Julie, and it's accompanied by one from Deborah, because the two are related. But she's asking, and you guys will probably know what this acronym represents, but Julie's asking, why does the informed consent form, so you'd mentioned that earlier, Dr. Downing, why does that informed consent form, when I'm getting vaccinated, ask about whether I'm allergic to PEG? So I guess that was that substance that you're referencing. And then Deborah's asking, are there particular things in the vaccine that people with food allergies or an allergy to amoxicillin should be concerned about when it's their turn to get the vaccine? So a question about PEG and a question about amoxicillin, and what are the concerns there about allergies to either of those two substances? Maybe Dr. Downing first, and then Dr. Varlese.
Yes, please.
Yeah, so polyethylene glycol is it's part of how the vaccine is delivered, and so it is a component of the vaccine. There are some rare individuals that are allergic to it, and there are a number of products that contain polyethylene glycol. It's a medication we use as a laxative. It's also incorporated into some cosmetic products. It has not been used in a vaccine that I'm aware of. And so, nor in most medications that I'm aware of, including amoxicillin. So I think if there's any concern, certainly ask your physician about your allergy history, and if it's a concern, and looking specifically at that one component, polyethylene glycol, in terms of whether it might be linked to that allergy. But in general, it's the cosmetic products that have been flagged, but not other drugs or vaccines.
Dr. Varlese, did you want to add to that?
Yeah, I mean, the other things to consider that are part of the vaccine are, there's a fatty coating layer to protect the mRNA. There's nothing that the body doesn't recognize, and a combination of, salts and sugar and water, basically. Like it's the rest of it is absolutely natural. So yeah, I mean, really, it's the polyethylene glycol, the only potential concern, and as long as it's addressed.
Can I ask a very basic question, just using, again, moderator's privilege here? But if one is, earlier you talked about herd immunity, Dr. Varlese. If somebody is out there and says, and they say, well, I've already had COVID and I recovered from it.
Yeah.
Why do I need a vaccine? Like, haven't I built up that immunity myself? What's the response there, Dr. Varlese?
So that's a question that I've been getting a lot of myself, and so really, first of all, it's the vaccine itself is not, it doesn't cover you 100%. So when we say 94, 95%, there's always that little segment of people for which it may not work. We understand that, but on the other hand, really the vaccine is meant to decrease the severity of the illness. There's a lot that we're getting to know about this condition. So far, the evidence is that if you had the disease, it is not 100% clear about the quality of the immunity that you've developed with an infection. We talk about the length of this immunity that you develop. How long is it going to last? You've heard it over and over. We're not sure, 3 months, 4 months, 8 months, number one. Number two, is the quality of the immunity you received with the natural infection significant enough and enough to cause, enough to prevent the next exposure that you have? And that's why we are advising, because the vaccine in all likelihood is going to be able to give you the type of immunity that really does have an impact on preventing.
Dr. Downing, anything to add on that? Or I've got
No,
lots of
no.
other. Okay,
Yeah.
great. I've got lots of other questions in the feed here, so and still a couple of pages of my own. So there's lots that we can ask you guys. So another question relates to vaccine supply, and this might be more directed towards me. But is there a problem with the delivery of the Moderna vaccine? Where is it coming from? That's being asked by Jennifer. Marty is asking, is the AstraZeneca vaccine under review by Health Canada? So I'll take an initial stab at both of these, and you guys can pipe in. I do know that AstraZeneca is currently under review, as I mentioned a little bit earlier, as is the Johnson & Johnson strain, which is called Janssen. That's their sort of vaccine development arm. I do know, for the purposes of the viewers' benefit, that the AstraZeneca one has the benefit of being a little bit less expensive to develop, and there's a lot of prospective value to that vaccine, from my understanding, in terms of spreading it around the world, including in developing countries, so that we can have broader immunity globally. There is no identified problems with the arrival of Moderna vaccine at this point. I'll confess I don't know which country it's originating in. I can say with assuredness that it is not Canada. It's not being domestically produced, but I'm not sure where Moderna originates from. I don't know if either of you gentlemen want to add anything to that, or if you're aware of where Moderna is being produced. Probably not Italy, because Dr. Varlese would have told us by now.
No, wait,
That's a-
I've been following the tracking of Pfizer much more closely because it's the one that's coming to Unity Health. But yeah, I'm less clear on where Moderna is coming from or
think
where it's
they're
going.
Yeah, I know that Johnson & Johnson is in New Jersey. I think Moderna, in Massachusetts somewhere.
Okay.
Yeah, and obviously, Pfizer right now in Germany, and sorry, not yes, in Germany, and then Astra. You mentioned about Health Canada for AstraZeneca. That is exactly what's happening. My understanding is that the government is securing 20 million doses as we speak. I heard this through some political groups so far. I may be wrong, but and it's very reassuring that they're doing that. But Health Canada is still going through the approval process, and that's what I'm hearing. Even though they're trying to secure this, it's like, it's the cart, before the horse,
Yeah, it's the chicken and the egg issue. And you're absolutely right. In terms of AstraZeneca, it's 20 million doses. Moderna, it's 40 million. And Pfizer, it's up to 76 million. So there's copious amounts of all of these. Johnson & Johnson, it's up to 38 million. Those are the contracts that we've signed.
Yeah.
But the delicate balance that we have, and this will not be news to any of the people viewing on Facebook, is that we as politicians don't purport to understand the science, nor do we purport to direct this process. It needs to run its own course. We're just empowering Health Canada to do that shift work and have enough staff to make the approvals happen. But we're not dictating the approvals because that would be untoward. So that's what we're studiously avoiding. I've got a question in from Carol, and Carol says, I too got my vaccine from St. Mike's. I'm waiting for the second shot at the end of January. No side effect from her first shot, but I've heard that the second shot is a bit different. And I guess I'm inferring by that she means that maybe there could be other side effects from the second shot. Is that a valid or legitimate concern, she's asking? So maybe Dr. Downing, do you want to take, I know neither of you, I don't think have had your second shot, but if you have any sense of a response to this question.
Yeah, you are more likely to get side effects after the second shot, and again, it comes back to that immunity. So your immune system now understands and recognizes the vaccine for the second dose, and so it gets more excited as a result. And so it's the same thing again, where a little bit of side effects probably means it's working well, but we are finding that the side effects are more common, not necessarily more severe. But they're more common. And so I think if you are a healthcare worker, which it sounds like you might be, or an essential care giver, then you definitely want to think about the day after the vaccine and taking it easy if you are having any side effects. Not that those are common, but in the event that they are, that's our advice to individuals.
Okay. Thank you very much on that. And is there any like, again, to my understanding, Moderna, because it can be stored at -20 versus Pfizer at -70, we've targeted delivery of that vaccine in different places. So in the north, for example, it's been easier for us to deliver it to the north and ensure that indigenous communities are being looked after, for example. But let's say all things were equal and there was two sort of options out there. Do you have any best practices or advice for people who might possibly, maybe we're not there right now, but at some point in the future have a choice between a Pfizer or Moderna? Is there anything that should inform them, or is it simply you take what's just being offered to you? Like, any views on that, Dr. Varlese?
Oh, you take what's being offered. I personally, I think that they're very, very comparable. If you really get into the more specific, I mean, the mRNA is synthetic when it comes to the Moderna vaccine versus the Pfizer one, but fundamentally we're talking about the same vaccine, and I personally would not make any difference between one and the other at this stage. But Mark, and perhaps you have a different opinion there.
No, I think they're essentially interchangeable. It's really just the challenge around the cold chain for Pfizer, kind of limiting where we can provide it, balancing with the fact that it sounds like we have way more of it. So I think those are really the main factors in deciding who gets what. So as you've said, Moderna has gone more to long-term care and remote communities, whereas Pfizer is more of a hospital-based approach in Ontario. That's where the depots are.
And can you explain to people just what is the cold chain? Because again, we have that term thrown around a lot, but I'm not sure if everyone fully understands this. What is the cold chain? What does that refer to?
Yeah, it's kind of critical that you maintain the process of keeping the vaccine at a certain temperature for a certain amount of time up until when it's delivered to the patient. And so if you look at Pfizer, they very carefully monitor the temperature in transit from the factory to the hospital. And if at any point it comes above -80 with their thermometers that they have, we don't consider the vaccine to be good anymore. And so that is a very careful step that needs to be maintained. And then once you thaw the vaccine, you have a certain time frame to store it in a refrigerator. And then again, at room temperature, you have a certain time frame before we think that the viability of the vaccine goes down. And so that's really the most important difference between the two vaccines at the moment.
Okay. And can you tell me in terms of let's go back to sort of where we were about the side effects and who it's been tested on and who it hasn't. I think it was Dr. Downing, you mentioned that, you know, you have to indicate you're 18 years of age or older because it's not been tested on younger cohorts. Are there any other bright line exclusions? I think you mentioned sort of breastfeeding or pregnant women. That would be an area of concern. But are there any other bright line exclusions where people should sort of self-censor themselves out of the cohort that should be going in and potentially getting vaccinated?
Yeah, I think the rest should be encouraged to get vaccinated outside of the polyethylene glycol true allergy that we've talked about. Even with children, there is some room within the NACI document for younger children that might be at risk of severe complications from COVID. So if you have a child that's 12 years old that may be a risk, it's still a conversation you can have with your physician. And at the end of the day, it's informed consent. But in turn, the pregnancy is the one in particular that we focused on. And did some work to make sure that that group could be vaccinated if they wanted to be. And while they weren't included in the initial studies, there's a long history of using drugs off what we call off-label for pregnancy because there aren't any studies. It's just the nature of being pregnant is that there usually aren't studies to show that drugs are safe, but we know through experience and through science that they generally are. And the other thing is that we know with COVID, if you get COVID when you're pregnant, it's estimated you're about 5 times more likely to be hospitalized than if you don't have COVID. So it gets back again to that risk versus benefit. And the very real risk of getting COVID, if you're in one of these vulnerable populations like being pregnant or having an autoimmune disease, versus the fact that we don't really know, we don't have the data to support that the vaccines work in these populations, but we can infer some of that. And really what it comes down to is the risk is really that the vaccines may be less efficacious, but we still think they're as safe because they're not live vaccines.
Okay. Those are important points. Anything to add on that point, Dr. Varlese, or should I go to the next question?
Yeah, just case by case situation for sure. You know, there's all sorts of other things. If a person has an autoimmune condition, you sit down with your physician and you go through the process of benefit versus risk. You know, originally transplant patients, for example, were not being given the vaccine, but there's change in that thinking. Again, benefits versus risk, and again, it's very specific to the case. There's lighter potential contraindications. A lot of patients that are aging tend to be on anticoagulants, for example, or there could be a bleeding disorder. Just the injection itself, you know, could be a bit of a risk. But again, those are smaller risks that need to be weighed and discussed with your physician. It's a benefit versus risk discussion that you have with your trusted physician.
Okay, that's an important message that's coming across loud and clear, is that people should be approaching their GP, their family physician, just to have some of these questions and raise some of these concerns and have these conversations. Pat has asked about a question that's sort of about a bit about sort of identifying resources and accessing them. She's just asking, is there a list online somewhere indicating where I or others around here could go to be tested? So I don't know if you had any thoughts on that. I'm thinking that perhaps Hamid could provide on Facebook one of the website locations. Primarily, Pat, what I would offer as the elected representative on this panel is that we're getting the vaccines into the country, federal government's job, and then the delivery of the vaccines is prioritized and then administered by the province. So Ontario's websites, the various websites that are available, are listing some of the vaccination locations. Obviously, there was one that recently opened here in Toronto. It is being put on hold while the Pfizer rollout continues after the week of the 25th. But that resource could be found, and I'd ask Hamid to put that into the feed on Facebook. But either Dr. Downey or Dr. Varlese, if you want to contribute to any online resources that you might know of where people could identify where can one go to get vaccinated when the time comes. Dr. Downey, do you have any thoughts on that?
No, I think like you said, the ministry websites are where that information will be.
Absolutely. Second that.
And can you guys, because I guess most people's familiarity with vaccines, we've talked about this a little bit as we've weaved through this conversation, but it tends to relate to the flu, right? And we heard about the flu shot because one, we're familiar with that. And we heard about the necessity of getting the flu shot this year in particular because we don't want to overwhelm the hospitals with flu patients when they're already getting overwhelmed with COVID patients, for example. But can you just unpack that a little bit? And then specifically, can you let people know that whether getting a COVID vaccine obviates the need to have a flu shot? Like, is it one or the other, or should people be pursuing both if they haven't already had a flu shot? And how does this compare in terms of just physical discomfort? I remember the muscle soreness from the flu shot, as I mentioned. Is it roughly the same sort of personal experience for an individual? So some of those, if you could address some of those questions, that would be terrific. Dr. Varlese?
Yeah, so, what's unique about this year is that anybody getting any symptom, even the sniffles, I think that we all appreciate that we're always thinking about COVID first. And so everything seems to become COVID until proven otherwise. The fear factor, the anxiety of the community, this is an important aspect. So we know already the importance of flu vaccination in our community. We have many years as to why it is important and how it by itself has a significant impact on mortality and morbidity, meaning on developing the disease, getting hospitalized, etc. But by being even more aggressive, with flu vaccination, you cut the chances of developing symptoms that will make you think about COVID first. Because as I said, unfortunately, we've been kind of used to thinking it's COVID till proven otherwise. And yes, this discussion eventually leads to overwhelming hospitals. There's a lot of people, a lot of patients that are wanting to go to the hospital even with very mild symptoms, just because of the fear factor. Now, it's also very interesting to see that because of the incredible effort that the community has put in with being cautious, washing hands, wearing masks, keeping distance, that the flu incidence has diminished, whether it's because of a combination of better vaccination process with the flu, but also behaviors. Again, the tendency is that it's COVID until proven otherwise, unfortunately, and more important than any other year, is it important to get the flu vaccination for that reason.
Maybe the one thing I would add is you shouldn't get the two vaccines at the same time. So the one caution is that, and this is a contraindication for the vaccine, is having had a recent vaccine for something else. And the reason that is primarily is because it'll be hard to distinguish if you get a reaction, which vaccine it was from. So I totally agree. It's been an amazing flu season, we haven't had a single case at St. Joe's that I'm aware of, which is unheard of. But it's so important to get your flu shot, both to prevent flu, but also to keep the water less muddy when it comes to diagnosing COVID. And if you do, make sure you space them out by 28 days at least from the COVID vaccine.
Thank you. That's an important point. Thank you for that just nuts and bolts analysis. But I also think it's sort of salutary when you hear about the and compare the number of deaths that occur in a given winter in this country from flu. It is quite dramatic, and that's not to minimize what's happening now, but it's just to emphasize that there are lots of other very fatal concerns that affect Canadians all the time. We need to do our part across multiple fronts. IEA is asking, when do the vaccines become available for the general public? And what I'd say to IEA, and you guys feel free to jump in, is that, again, in terms of the delivery, it's the province of Ontario that's dictating that. We've got sort of what's called a phase 1 and then a phase 2. And again, from the research that I was doing earlier, the phase 1 is people, resident staff, and essential caregivers in congregate living centers for seniors, primarily, the healthcare workers that relate to those environments, and adult First Nations, Inuit, and Métis. And then there's a second phase, where the province is indicating that it would be older adults, beginning with those who are 80 years and older, and then decreasing in 5-year increments, so 75-year-old adults, 70-year-old adults, et cetera. People who work and live in high-risk congregate settings. So you heard Dr. Downing talking about this. For example, people who live in shelters or community living. Then other frontline essential workers, including first responders, teachers, people in the food processing industry, et cetera. It's in phase 3 that you get to sort of the general public. And as to when we hit phase 3 or not, on a long-range prognostication, it's August. On an earlier prognostication, it could be a couple of months prior to that. But it really depends on how fast the rollout goes. I take some encouragement from the fact that in terms of targeting the long-term care homes in the most severely affected parts of this province, Toronto, Windsor, Essex, York, Ottawa, there's a couple of others that I'm missing out on. The province exceeded their target in terms of getting those areas vaccinated. So that's a very good sign, is what I would take some comfort from. Gentlemen, I have a question about, we talked about herd immunity. What is the target for herd immunity for this particular virus, for COVID? And because there are new variants, Dr. Varlese, you talked about the fact that we know at this point that regardless of the new variants in South Africa, Britain, et cetera, we understand that the vaccine is still working against that new variant. But does the new variant up the ante in terms of the percentage of the population we need to have immunized to hit herd immunity? So what's the baseline herd immunity number? And does that herd immunity number increase because there's more variants out there? So any thoughts on that, Dr. Varlese?
Yeah, so as I said before, I mean, there's 2 ways to get herd immunity, and one is without the vaccine, which is absolutely not advisable because the mortality or the number of deaths would be incredibly high. But and that's why the vaccination, which will deliver that immunity, will give us that herd immunity, and anything lower than 70 is not where you want to be. You really want to get up there with the number. I don't think that the different strains are going to change the issue on herd immunity. Once again, I'll say that the current vaccines will be able, so far, based on what we know, they will be able to cover the new strains coming from South Africa and England, South Africa mainly. But once again, that's why the vaccination process and program is crucial. I again predict that because close to 200 pharmaceutical companies have embarked in this incredible historical process of developing a vaccine in record time, I feel that others will join, and perhaps we will get to the finish line a bit earlier than the projection. Any projection today is as good as it is based on the data we have today. But when tomorrow comes and new information, new sort of like vaccines come into play, that may change. And so hopefully that'll be the case.
Thank you. Dr. Downing, anything to add on that?
Yeah, I think when it comes to, so in terms of is there a number we're targeting for herd immunity, what you will hear is 70-80%, somewhere around that is a good start. I think we'd like to see higher, but I think that's where you start to see good numbers. And that's what we're targeting with our long-term care homes in particular. And so when you see staff, essential care providers, and residents all getting above 80%, that's where I really say, okay, you're good. Like, I'm not worried about a serious outbreak in this facility anymore. So I think that's what we'll start to see in a large scale. I think in terms of the variants, it's yet to be seen. I'm fairly convinced now that these variants are possibly more contagious based on some of the modeling, and so I think it's yet to be seen what that means, but we do still think the vaccines are effective. It's just you probably have to vaccinate that many more people to keep them in check, because it is circulating slightly or significantly more quickly than the traditional strains. And so I think it does provide some urgency, but it doesn't fundamentally change anything we do when it comes to IPAC, infection control, or the vaccine itself.
Got it. Thank you so very much. Margaret's chimed in with a question, but I think I have the ability to answer it because I've been taking notes as we've been talking. And she's asking about kids getting the vaccine. And I understand from you, Dr. Downing, that there's a box that you check off, like, are you 18 or older? So on its face, generally, kids are not meant to be receiving the vaccine at this point. But you did say it might merit a conversation with your physician if you have a child that may be particularly susceptible to COVID, were they to contract COVID. So if your child is in that unique sort of situation, have that exploratory conversation, because NACI, the national guideline body, has indicated that in some cases, a child getting vaccinated would be more beneficial if certain conditions obtain. Is that a fair assessment?
Yeah, and what I would say about kids is the studies haven't been published yet, but they're ongoing. And so that's partly why that recommendation has been made. But also kids do really well with COVID. We have seen some unfortunate and severe cases, but when you look at the group as a whole, kids tend to do well and recover. And it's what we worry more about is spread from a child to someone else in the household that's more vulnerable. And so I think that's why at the moment they're not a priority group, but they certainly will be in line once the data's there, I imagine.
Excellent, excellent. So it's 8:28. Both of you have been very patient with me and with all of the constituents, and you can see there's a flurry of questions coming in. So I just want to say, first of all, thank you. Thank you for what you do for a living. Thank you for working hard to keep all of us safe and healthy, and for your continued commitment to the people you serve and to our communities, for your work at Runnymede. And I agree with what you said, Dr. Varlese, about Connie DeJack. She runs a very fine institution. And I've only had the same impression with St. Joe's in terms of what you guys contribute to our community. I want to get back to the point where we're doing that Bloor West Halloween Fest with St. Joe's and doing things in person. That would be, nothing would please me more. But thank you for giving us your time, giving us your expertise. I took copious notes, learned a lot about muscle soreness being something to be looked for, as opposed to guarded against when you get a vaccination, about mRNA and about things like the NACI and about the specific contents of what's in the actual shot. So thank you for imparting with us some of your wisdom. In terms of my team, once again, thank you to Hamid and Hannes, and to Amelie and Dawn and Chris and Tenzin and Dave for all of the work you do for my constituents all of the time, in terms of helping us to serve all of you better. Please, if you're watching now, don't see this as the end of the conversation. This is only the start. Please take to heart what I said at the outset, that this is not meant to be judgmental in any way, shape, or form. My job, again, is not to pressure people or compel them into any sort of decision, but to just arm you with the best information possible so that you can make those decisions for yourself. That is the best service that I can provide to you. So I'm here to listen, here to address things where I can, and where I cannot, to bring in the heavies, such as the folks from St. Joe's and Runnymede, to answer some of the questions. So that's what we're trying to do. If you have further questions, there are resources available. I'm going to be shameless and direct you to the federal resource, but there are resources at every level of government. So the City of Toronto, at the provincial level in Ontario, and obviously there's the website that I mentioned at the outset, which is Canada reef.ca/vaccine. So great place to go to if you have questions about what is going on. If you wanted to point a directed question to me, please reach out to my office. The best route is usually by email. It's arif.varani@parl.gc.ca. Obviously, you've heard, regardless of where you are in this vaccination spectrum, maybe you've gotten the vaccine, maybe you're thinking about it. Regardless, there are public health guidelines that are out there, and we need to follow them as closely as possible to keep ourselves safe, our families safe, and our communities safe. So please continue to wash your hands, continue to wear masks, continue to keep a safe social distance. Download that COVID alert app. It can actually help. We know it has helped people in terms of alerting them to stay away from certain areas, given the fact that they've been in contact with someone who's tested positive. That's important. And it's also important to know that this becomes a resource. We've been recording this. This will remain on my Facebook page. You can view it after the fact. You can come back to it and consult it. You can encourage your friends, family, relatives, neighbors to do so as well, because it's here as a resource for you in terms of the medical wisdom that we've been able to share with these two fine professionals. So I want to say thank you. Should have said at the outset, merci beaucoup, and added a few words en français. Et on est tout à fait à l'aise à répondre à vos questions en français aussi. Donc, si vous voulez me contacter en français, on va essayer de vous répondre en français aussi, comme il faut au niveau fédéral. So thank you very much for your time. Gentlemen, thank you for your time this evening. Thank you for the work that you do in our community. And to all my constituents, please take care of yourselves, take care of your mental health, take care of your physical health, and stay safe. And we will connect again soon. And I'm hoping even one day physically we can connect again soon. Thank you so much, folks. Have a good evening. Take care. Good night. Thank you.